Before we begin today, I would first like to acknowledge the traditional custodians of the land that I'm on, the Whadjuk Noongar people, and pay my respects to elders past, present and emerging. So before we kick off, I'd also like to note that this webinar today is being recorded and it will be made available on the HealthInfoNet website at a later date. So I'm very excited to introduce our two guest presenters today. So we have Dr. Kerry-Ann O'Grady, who prefers to go by the name KA, and Dr. Kerry Hall. So KA is an applied epidemiologist and senior research fellow at the Queensland University of Technology's School of Public Health and Social Work and Institute of Health and Biomedical Innovation. Her multidisciplinary team's research focuses on the pathways from acute to chronic respiratory infections in children, with a particular focus on Aboriginal and Torres Strait Islander children. The team's work includes non-experimental studies, vaccine trials, and trials of interventions to both prevent and manage disease. And we also have Dr. Kerry Hall. Kerry is a research fellow at the School of Human Services at Griffith University. Kerry is an Aboriginal woman from Cape York Peninsula and has been an endorsed enrolled nurse for more than 30 years and an Aboriginal health practitioner with extensive experience in Aboriginal and Torres Strait Islander health and education. Her PhD project examined the incidence, predictors and outcomes of acute respiratory illnesses in urban Aboriginal and Torres Strait Islander children aged less than 5 years in the community. Our two presenters today were both the lead authors of a review that the HealthInfoNet released not that long ago on respiratory diseases among Aboriginal and Torres Strait Islander children. So at the end of the webinar, we'll have about 10 to 15 minutes for you to answer any questions. And then after that, I'll be showing you a couple of new products that the HealthInfoNet has been working on as part of the respiratory review. So I'll just switch my webcam off now and I'll hand over to KA and Kerry in Queensland. Thank you both.
Thanks, Millie. Welcome everyone. It's Kerry-Ann here and Kerry there.
Hi everybody.
Thanks for joining us. We hope that you get a little bit out of today. We're not doing just a repeat of the review. I think people can read that. So we're just going to expand on some of the points that we've raised in the review with a particular focus on sort of the absolute lack of data that we really do have about respiratory illnesses in these children. So I'm just going to hand over to Kerry to acknowledge traditional owners.
Hi everybody, thank you. We would like to acknowledge the traditional owners of the land on which we meet today and pay our respects to elders past, present and emerging. Just a couple of caveats before I go on. Aboriginal and Torres Strait Islander groups may vary with regard to geography, socioeconomic status and local customs. And Indigenous as a descriptor belies the heterogeneity among cultures, lands and belief systems that impact on perceptions of disease and treatments. And caution is required in generalising data from often limited information to all Aboriginal and Torres Strait Islander people, particularly applying data collected from remote communities to urban communities and vice versa. Just a bit of an overview on today. So we're going to talk about respiratory illness in Aboriginal and Torres Strait Islander children. What are the gaps, what are the challenges, and what needs to be done in the future. What we know, respiratory diseases, acute and chronic, 8% of disease burden compared to 2.5% in non-Indigenous Australian children, 8% of the deaths, 31% self-report chronic disease lasting greater than 6 months. Self-report higher in non-remote, 35% than remote at 18%. 9.5% of hospitalisations excluding dialysis. 2.4 times the non-Indigenous rate, and COPD and pneumonia are the most common diagnosis. There's very little data or report specific to children.
So what we have is we predominantly use around the country is data from reports such as the Health Performance Framework, and a lot of the data that we rely on to look at burden of disease and monitor trends over time is actually pretty limited to hospitalisations and deaths data. And the latest Performance Framework report from 2017 presented the age standardised hospitalisation rates for all respiratory diseases by Indigenous status and sex, and you can see over time over the various states, that in all states and territories the burden of the rate of hospitalisations is much higher in Aboriginal and Torres Strait Islanders than non-Indigenous Australians. The problem with a lot of the data in these reports is it's very difficult to extract out data specific to children, and particularly in specific age groups. They tend to get lumped into age groups of less than 15 and 15 and over. The other thing is that a lot of the reports just use respiratory disease as an overall heading, and so it gets quite difficult at times to actually drill down and find condition-specific things. So a lot of disease will be lumped into ICD codes such as influenza and pneumonia for the acute diseases, and then your chronic ones of asthma and COPD. And as we'll show a little bit later, there's some problems with that when you're actually trying to address specific respiratory conditions in children. With respect to deaths data, again, it's a bit of the same problem, is that trying to find good data, it seems to all end up being lumped onto these broad categories of respiratory diseases. What we can see from this graph from the latest report is that we've still got this big gap between Indigenous and non-Indigenous Australians, and while we seem to have a decline that was things seem to be heading downwards in the first half of the 2000s, we now seem to have just plateaued out, and nothing much has changed, with even possibly a slight increase again on mortality from these diseases. The reasons for that are actually not all that clear at the moment. One thing we do know, though, which is what Australia has done well, is that our children don't infrequently die of pneumonia now, and that's due to better clinical care rather than actually the prevention of pneumonia itself. The other problem that we have is that, again, these sort of national and even statewide reports very muchly disguise differences within regions and areas across the country. So the data that's on the slide now is from an assessment that we did here in Queensland in 2011. It was a lung health needs project, and we mapped out chronic respiratory diseases by what's the Queensland Health Service districts. And as you can see, there's quite wide variation within and across the state. And I think an interesting thing here is that a lot of the focus on respiratory health in Australia, in Aboriginal and Torres Strait Islanders to date, has been on those in remote areas. Whereas you see from here that, at least in Queensland, it's actually the regional areas such as Central, West, Darling Downs, Southwest area, Mount Isa district in particular, which have far higher rates of disease than what we're finding up in the areas such as Cape York and the Torres Strait, where there tends to be a lot of focus. But it even highlights here that in the urban areas, which is Metro North and Metro South, there's still significant disparities between Indigenous and non-Indigenous Australians in Queensland.
So next we're just going to go on to the importance of local data. This data comes from my PhD project, which was looking at urban children in a community setting. 39% of the children were from single parent families. 46 are of Indigenous families have family from the stolen generation. 37.7% of mothers and 45% of fathers did not finish high school. 42% of fathers and 85% of mothers were unemployed. 76% of the households had an annual income of less than $52,000, and of that 38% had a household income of less than $26,000 a year. 90% of parents and carers are on welfare. 5% had private health insurance, and scarily 78% of children are regularly exposed to tobacco smoke, very environmental or direct. So there's been one community-based paediatric study in the past 10 years. There were children under 5 years. ARI with cough incident in 180 children, there was 24.8 child months at risk. 10.5 of those children went on to experience recurrent ARI. 25% of those resulted in a chronic cough. And the most common reasons for health service utilisation was respiratory illness. Prevalence and risk factors were similar to remote children, and the cost of ARI, which has not been done in an Indigenous urban population, was at $991 per child per year, and approximately half of that was borne by the parents. And in some children, it was as high as nearly $1,500. And there's limited data on health service utilisation and disease outcomes in these populations. Similarly, we looked at immunisation timeliness in this population as well. I can't really see that slide.
Sorry,
at the 6 month mark, when children should be up to being fully immunised,
47%.
About 47% of them are meeting the immunisation as per the Queensland immunisation schedule. That data has been supported, our small community work has been supported by a larger study by Hannah Moore et al., who looked at the National Data Linkage Study about immunisation timeliness and coverage in subgroup populations. Parent carer perspectives. There's a lack of studies addressing perspectives of parents, carers and communities. Bell, in 2016, did some qualitative work before my PhD study started. So she looked at some of the families, and we did many focus groups with that, looking about parental concerns around respiratory illness. And I was just going to talk about a case that came out of my work. This little girl was four years and 50 weeks old when I approached her mother. So she scraped into the study by 2 weeks, and she was at that age. And in that previous 4 years, her mother had been told she'd had a chronic cough. She'd been coughing since she was 1. Her mother had been told it was poor behaviour, the child was bunging it on. It was bad parenting, all sorts of other social factors that were apparently making this child cough and chronically ill. She was on the program for 2 months and was ultimately diagnosed with bronchiectasis. So that's the sort of thing. The mother hadn't been listened to or heard for the previous 4 years. So we did hear a lot of that. And work by De Silva has supported our findings. It's a qualitative study that's just come out of WA. There's lack of information about health literacy and the sense of disempowerment and belief that nothing will be done because doctors or the medical professions don't listen to these parents, or cough is normalised as being a normal part of growing up.
Oh, sorry, everyone, the button's not working. Oh, there we go. The other thing that's come out in our studies that we've been doing is associations with historical trauma, and it's one of those things that everybody talks about, and the impact of things like stolen generations on health. But they've not, and there's quite a few qualitative studies that are coming out now, but there's very few studies that have actually started to go, what's the quantitative associations between this trauma and actual disease? In one of the community studies we did here, even though it was a cross-sectional survey, being connected to the stolen generation increased the risk of having respiratory symptoms by nearly 3.5 times. So that's the adjusted odds ratio. That's adjusting for all other factors such as age and sex and smoking, and it was the strongest predictor of respiratory symptoms in these young children. Being connected with the stolen generation was also associated with a higher cost of illness over a 12-month period, which makes sense. If these children are having more symptoms and more recurrent affections, then it's going to be costing those families a lot more. There's now, I'm not sure if people are aware, a large cohort study being set up by Ray Lovett at ANU in Canberra, which is actually going to focus on this association between the stolen generations and actual physical health and well-being in Australian Aboriginal and Torres Strait Islanders, and that's a large study that's being done across the country. And I think the other thing that's highlighting this is the latest ARHW publication, which has looked at the links between stolen generations, their descendants, and various selected socioeconomic and health outcomes. And on this next slide, we can see that chronic health conditions are far more likely in descendants of those from stolen generation than they are were in descendants that weren't from the stolen generation. And you can see up there that your respiratory conditions such as asthma, bronchitis and emphysema are prominent in that burden of disease. So I think there's going to be a lot more work coming out now looking at that relationship between historical trauma, the stolen generations and actual physical health and well-being, rather than the traditional things we focus on such as smoking and diet and nutrition and exercise, etc. We know that there's, from the review, if you go through that there's a whole lot of gaps on respiratory disease in Aboriginal and Torres Strait Islander children. Most of the studies and the data that we do have are now more than 10, if not 20 years old, and given changes in things like immunisation schedules, differences in implementation of various management guidelines, all of that sort of thing, we really don't have any contemporary data that can actually give us a really good idea of how we're tracking with respect to the burden of disease, other than this general category of hospitalisations. And given that a lot of people are now being more frequently managed in the community, particularly with respiratory illnesses, I think if we continue to rely just on hospitalisations data, we're going to be missing out on a lot of important information. We have a significant lack of data by urban, rural, remote and different geographic regions of the country. So even most of the work that comes out around respiratory illnesses has been done in the Western Australia and the Northern Territory. And as we can see from some of our work in Queensland, there's a lot of similarities, but there's also a lot of differences. Also, we have a large amount of gaps on the etiology of disease in children, and where we can actually intervene has been largely understudied. So in amongst all of that, the data on Aboriginal and Torres Strait Islander perspectives are really scarce. So as Kerry said, there's now a couple of qualitative studies coming out that are actually starting to look at what parents and carers' perspectives of respiratory disease are in their children, the effects of it on their children, their families and their communities. And sorry, we've just had a door opened in here. And we also don't have things such as health-related quality of life tools that have been validated for use in Aboriginal and Torres Strait Islander children that can actually be used as patient-reported outcomes in both clinical and popular public health studies and interventions. And that work is only just starting now. There's a group in Sydney starting to develop a tool for adults, and we have a student within my group who's developing one for children.
The challenges, longitudinal studies are required, commencing in the prenatal period with long-term follow-up. Expensive and logistically difficult with complex populations. Diagnostic challenges remain, including coding, influence both sensitivity and specificity of case definitions. Normalisation of cough is common and problematic. While the focus on social determinants is important, however, interventions are needed now to reduce the burden, and finding Aboriginal and Torres Strait Islander researchers and clinicians to lead and guide the work.
Some of the challenges around etiology, this is some work that's been done on the prevalence of viruses and bacteria in urban Indigenous children. So we try and target things such as vaccines and even the use of antibiotics. And unfortunately, determining etiology in respiratory illnesses in children is challenging, particularly lower respiratory tract infections, because sticking an endoscope down and taking a lung, doing a lung tap or getting lower airway specimens is just not feasible in most settings. And so a lot of studies, and even clinically, would be relying on the good old nasopharyngeal swab or NPA, and yet the work that's now becoming, there's several places around the country that are now showing that those upper airway specimens are really unreliable, given these children have high prevalences of viruses and bacteria and co-detection of both viruses and bacteria, even then when they're well. So trying to work out what's the causative bug gets particularly challenging. This was also highlighted in a study that Anne Changar did in Central Australian children, looking at the relationship between upper airway microbiology and respiratory symptoms in children that had been hospitalised with pneumonia, and there was virtually no associations that could be identified with any of the main causative organisms which were found in upper airway specimens. So even just sort of, as I said, trying to target the bugs causing these infections is particularly challenging because we can't quite work out what's the main organisms responsible at the time a child is sick. So some of the other data challenges that we have, this is some other stuff that came out of Queensland. If you look on here, this is a table that says the average annual age-specific COPD hospitalisation rates per 100,000 population. If you actually look, there's actually COPD hospitalisations in children under the age of 15. COPD is not a paediatric diagnosis, so this is hospitalisation data, and this has come about because until recently there was no code specific to bronchiectasis, so they were all being chucked in as COPD. That has now recently changed in that bronchiectasis has been added to the codes from July 2018. So hopefully we can even get some better data now on children's hospitalisations for chronic respiratory diseases other than asthma, whereas previously they were all just being chucked in under adult diagnoses. We have several funding and policy challenges, and some of these are experiences I've had in a couple of arenas over the last couple of years. We're doing very well at stopping our children dying from respiratory diseases such as pneumonia. Unfortunately, what that leads to is a bit of a decreased attention on those diseases. We don't have the photos of children dying of pneumonia that match those of, say, whooping cough, for instance, or a child who's dying with cancer. And so it sort of tends to get overlooked because it's not a major cause of death in these children. There's also a very big focus on COPD and asthma, given the burden of disease in adults. And there's much less attention paid to paediatric disease, yet paediatric disease is the key predictor of adult lung disease. It's now quite a fair bit of evidence that the more acute respiratory illnesses you get in the first couple of years of life, the more likely you are to go on to develop COPD, irrespective of smoking status. And yet we're still not getting enough attention paid on the respiratory health of young children. Getting pharmaceutical companies and vaccines to participate in some of these studies is really hard. We just had an experience last year where we put in a grant for a vaccine intervention in these children, and the major response from reviewers was that the study should be funded by industry, not the government, and that has its own problems in itself. Some of the problems that we have in getting good evidence and good data is the size of the study population that you need to demonstrate effects is so big that the studies become largely unfeasible, particularly if you're trying to do those in remote areas. They become prohibitively expensive. And there's also a bit of an international perspective. I was at a large WHO meeting a couple of years ago, and we were talking about respiratory disease in kids, and that we have this excessive burden in Aboriginal and Torres Strait Islander children, and that some really high quality studies and work can be done in those settings that could be used to inform processes in developing countries. And the general consensus was that Australia is a rich country. We shouldn't be focusing on Aboriginal and Torres Strait Islanders. It's the Australian government's responsibility to fix it and pay for it itself. And you can sort of see where that picture comes from, but it sort of shows on a bit more of a global level where the problems we face in our own backyard actually sit.
So how data can lead to changes. Comprehensive assessment of lung health and associated services in Queensland led to the establishment of IROC, which is an Indigenous Respiratory Outreach Service, which covers Queensland from Brisbane up to the Torres Strait in both adult and paediatrics. From that, there was also spirometry training for Indigenous health workers, and there's been a suite of educational resources that came out of that. Studies in primary care of ED of AR in children led to change in clinical practice and funding of interventions for an RCT. And detailed analysis of epi, micro and clinical data from children with chronic disease led to NHMRC funded trial of maternal immunisation. There's an international bronchiectasis registry established with an Australian site. The first action plan from the National Lung Foundation looking at lung disease has been sent to the federal government, and bronchiectasis was added as a code to the DRGs in July this year. What's needed? So most of the studies in Aboriginal and Torres Strait Islander children are more than 15 years old, so we need a repeat of those studies. And we need to focus, I think, on the importance of a whole life perspective, just not now, but in the antenatal period, because it's becoming more known that what happens in the antenatal period can have lifelong effects. Acknowledgement of heterogeneity between communities and sites and states. Recognition of respiratory disease to all-cause morbidity and mortality. And community and provider education and engagement. Research is a powerful tool for achieving this.
So just some of the things that we're doing here to address some of those things. We have a number of randomised control trials that are now going on. So we've just completed an RCT of an early intervention, a clinical management plan in chronic cough in children. So we have this intervention implemented at the transitional phase from acute to chronic cough. 45% of participants in that trial are Aboriginal and Torres Strait Islander, and those results will be hopefully, once I get the analysis done, first paper should be submitted early in the new year. We also receive funding based on our local data, and we had an Aboriginal medical service that asked for us to address timeliness in their community. That led an RCT of an intervention to improve timeliness, which is we enrol mums while they're pregnant and follow the babies until they're 8 months of age. And that study has finished recruiting, and the last of our babies has been born and finishes up in May, the last bub then. So we'll have data that come out of that, but preliminary data that we have suggest it looks as if the intervention will is looking promising. We're just kicking off a maternal vaccine trial of the 10-valent pneumococcal protein D conjugate vaccine, giving that as a single dose between 27 and 35 weeks gestation, and following the babies till they reach 12 months of age, with infant ALRI as the primary endpoint. There's a whole lot of immunology and microbiology and fancy lab stuff that's going on with that. That's funded by the NHMRC. Anne Chang, I should say, is doing a couple of trials on the duration and types of antibiotics for children with pneumonia and bronchiectasis. We finished a vaccine trial of the 10-valent pneumococcal protein D conjugate vaccine in children with chronic lung disease. We have just received NHMRC funding for a trial looking at tailored exercise therapy for children with bronchiectasis. So rationale behind that is we know these kids have difficulty engaging in routine exercise. So a pilot study done here demonstrated that a tailored exercise program improved clinical outcomes, quality of life and lung function. So that study is now being extended to a full RCT. And Anne's just got funding to do a trial of tailored bronchiectasis management plans in kids with bronchiectasis. Other things that we've got going on here is there's actually several cohorts of the development of chronic cough, post-acute respiratory illness. We have a student who is developing the parent proxy paediatric health-related quality of life tool for use in Aboriginal and Torres Strait Islander children, and the plan for that is to develop a respiratory specific tool that can be used. There's qualitative work going on, and another one about to be will be starting next year on perspectives of maternal immunisation, which is getting really important given there's already 2 vaccines for pregnant mums, which we know the uptakes remain poor. In the next 5 years, there's going to be an RSV vaccine for women in pregnancy, excuse me, and probably a couple of others that are still in the pipeline. So we'll have a crowded infant schedule, but we'll also start to see a crowded maternal schedule. And so a lot of work needs to be done to have a good understanding of what the issues around that are going to be. There's a long-term cohort study going on the long-term outcomes of protracted bacterial bronchitis. And we have several studies from different populations where we're looking at detailed costings of acute respiratory illness and the associated interventions. So that's just sort of some of the stuff that's being done with collaboration with partners in the Northern Territory, WA, and some of the southern states, as well as in Malaysia and Alaska and New Zealand. So that sort of wraps up our short but sweet overview, and just want to acknowledge all the work that we do is a contribution from a very large number of collaborators and families and research groups from around the country. So that's it from us, and we can hand over, Millie.
Excellent. Thank you very much to you both for that excellent presentation. I'd just like to open up now for questions. So if anyone has any questions, feel free to type those in the chat box, and we'll get Kaya and Kerry to answer them as they come up. We'll give it a couple of minutes, we'll give it a minute or two, and if we don't get any questions coming through, what we'll do is we'll switch over and have a quick look at the video and the infographic, and people can ask, think about questions or type any in the meantime.
Sure.
Okay, it doesn't look like we've got anyone typing anything, so while we're waiting, we'll just switch over and have a quick look. So you should now be able to see the homepage of the HealthInfoNet website. And basically, as part of our commitment to making knowledge more accessible, when we do our narrative reviews, we also like to develop a suite of resources to accompany these reviews. So we've been working on an infographic and a short video, which kind of aim to provide a quick summary of some of the key points contained in the review of respiratory health among Aboriginal and Torres Strait Islander children. So you can find these if you go to the Learn menu at the top of the page, and then you just navigate down to respiratory health under health topics. Right. So the respiratory health section is kind of the main section on the website where you can find all the information on respiratory health, and it's split into content types such as asthma, lung cancer, risk and protective factors, and more. And if you scroll down a little, you can see we have a knowledge exchange products section down here. So the first one I'll show you is the fact sheet. We just scroll down and click on this. I'll just make it a little bigger. Okay, so this is the fact sheet we've developed, and basically it's just a one-pager with some of the key information that Kaya and Kerry have highlighted in the review. And this is all accessible on the website, so if you wanted to take a closer look, please go ahead. And then going back to the respiratory section, we'll just have a look at the video. So I'll just get you to mute your own microphone, Kaya, and I'll put the volume up really loud so that everyone can hear this. Respiratory illnesses in Aboriginal and Torres Strait Islander children are serious, important, and the progression to chronic lung disease is mostly preventable. Respiratory conditions of concern among Aboriginal and Torres Strait Islander children include both acute and chronic conditions. For acute conditions, these include acute respiratory infections like influenza and bronchiolitis. For chronic conditions, these include asthma and bronchiectasis. Currently, there is not a lot of data on the status of respiratory health among Aboriginal and Torres Strait Islander children, but what we do know is that in 2012 to 2013, 1/5 of Aboriginal and Torres Strait Islander children had a long-term respiratory condition. In addition, in 2014-15, Aboriginal and Torres Strait Islander children were up to 2 times more likely to be hospitalised for respiratory conditions compared to non-Indigenous children. Respiratory conditions contribute to the burden of disease for Aboriginal and Torres Strait Islander children. Lower respiratory tract infections were the 8th leading contributor to the burden of disease for girls 5 years old and younger. Upper respiratory conditions were the 10th leading contributor for girls 5 to 15 years old. And asthma was a leading contributor to the total burden of disease for all Aboriginal and Torres Strait Islander children. Risk factors for respiratory diseases include environmental factors like overcrowding and pollution, unhealthy diets, low birth weight, exposure to tobacco smoke, anemia, and socioeconomic status. There are many prevention strategies that can reduce the burden of respiratory disease for Aboriginal and Torres Strait Islander children, including a focus on child lung health, improved infant health, healthy diet, reducing environmental tobacco smoke, vaccinations, prevention of smoking among young people, and education and empowerment of parents and carers. Respiratory diseases can have long-term impacts across the lifespan. Despite this, there is a lack of current available data. There is also a need for adequate data on children in urban and regional areas. This information will be crucial for ensuring programs, strategies, and interventions are relevant and acceptable. However, there is much that can be done now to enable Aboriginal and Torres Strait Islander children to breathe easy through their lifetime. Excellent. So that's the video. What I'll do now, it doesn't look like we have any questions, but I'll pop up the slides again, and that will have our contact details on there. So if you'd like to get in touch with either KA, Kerry, or myself, you are very welcome to do so if you have any questions later on, or if you have any feedback as well about the video. So that's our details there. Alrighty, I guess we'll wrap up unless anyone's got any other comments. And thank you so much to Kerry and Kerry-Ann. We really appreciate you taking the time to have a quick chat to us today. It was great. Thanks very much.
Thanks,
Thank
everyone.
you, Thank you, everyone.